what's in the near future?
Sure, yeah, happy to. Well, first of all, thank you for inviting me to talk. As you said, I won't have met most of you before, so I can tell you a little bit about me. Obviously, I'm Irish. You can pick up from the accent. I trained as a physiotherapist and completed my PhD in Trinity College in Dublin in Ireland, and then completed postdoctoral research on 2 aging cohort studies in Ireland before hopping on a plane and going to Canada. In Canada, I worked as a physio and then completed a 3-year postdoctoral fellowship at the University of British Columbia. And that fellowship focused on secondary analysis of administrative data to look at the association between timing of surgery after hip fracture. And in 2017, I then moved to King's, where I have been ever since. My interest lies in trauma rehab for older adults. And I think I perhaps submitted an overly ambitious title for this talk. So today I'm going to focus on some of the work my group is doing to address some of the uncertainties in rehab after hip fracture. So how are we doing this? Well, first, data. So I'm a strong believer in using data that's already available. If it's handled appropriately, it can be used to inform quality improvement initiatives, and findings can spark new research questions. And then trials. So we have one trial funded to develop and assess the feasibility of a data-driven stratified approach to rehabilitation. And we have another feasibility trial, which is currently under review with NIHR. Before going on further, I wanted to highlight that all of the research is underpinned by our fantastic public and patient involvement group, TROOP. So our group meets quarterly with additional meetings on an ad hoc basis. There's 8 members of the group, and they've really driven some of the components of the trial that's under review that we will be talking about a little bit later. So today I thought I'd focus on an NIHR-funded secondary analysis study that has finished, so that I can give you some results of work that we've done, and then talk about how the results of that study led to the development of the feasibility trial, which is currently under review. The objectives of the secondary analysis were to determine whether mobilization timing was associated with survival and discharge after hip fracture surgery and survival and recovery at 30 days. And we also looked to see whether these associations varied across subgroups defined by characteristics of patients. So I thought I'd just say what we're talking about. I'm sure you're all very aware that mobilization is considered by the ability to sit or stand out of bed. And by the NHFD, early is considered the day of or day after surgery, and late is 2 or more days of surgery. So advocates of early mobilization suggest that getting out of bed early can reduce the chance of postoperative complications and therefore improve survival, and that early mobilization will reduce the loss of muscle strength induced by bed rest, so estimated at around 5% per day in older adults, increasing the chance of recovering ambulatory abilities. So in 2020, 81% of patients mobilized early in England and Wales, and this has really been relatively consistent over the last 5 to 7 years. But 49 hospitals were considered in the red for this performance indicator, with one site being as low as 36%. The actual evidence underlying early mobilization is quite limited. In the NICE guidance, they're relying on one trial of low to moderate quality. So we sought to generate new evidence to inform a decision as to whether or not this key performance indicator should translate into a policy for patients after hip fracture. So we examined data for just over 135,000 patients who were surgically treated for a non-pathological, isolated first hip fracture between 2014 and 2016. Mobilization timing was defined by early or late, and our outcome was survival on discharge. And it was identified by the presence of a discharge destination code of home or residential or nursing care. So when considering our analytical approach, we went back to our objective. So we looked to determine whether mobilization timing was associated with survival and discharge after hip fracture surgery. So the key aspect of this is survival on discharge. So it means we need to consider both survival and time to discharge. If we framed our analysis as a linear regression, we'd use length of stay as the outcome variable, and we would answer the question, what's the association between mobilization timing and length of stay among all patients originally entered into the study? But this question doesn't account for the fact that some patients die in hospital, which we have acknowledged in our objective. So a more appropriate question would be, what's the association between mobilization timing and discharge among those who are alive by a certain time? And this question places us in the world of competing events. So I'm not sure if you've heard of competing events, but it's an event which precludes the occurrence of the event of interest. So in this case, it's in-hospital death competes with discharge from hospital. More simply, only those who remain alive can be discharged to their home or to residential or nursing care. So failure to consider these competing events in the context where they are likely can lead to an underestimation of the incidence of your outcome of interest. So in this case, the incidence of discharge among So to actually implement this, we use something called a cumulative incidence function. To simplify this approach, we considered a sample which changes in size over time as a patient considers a competing event. So if at the beginning of a study you have 100 patients and at day 15, 2% have died, then we now have 90 patients who can potentially experience our outcome of interest. So for our analysis, the count of patients who could experience our event of interest was assessed daily for the first 30 postoperative days. We also considered censoring events, which is an issue when we're looking at secondary analysis of routine data. We considered discharge to a rehab unit, acute hospital, or another unit as lost to follow. We're not able to determine whether those patients went home or to residential or nursing care as an endpoint. And we considered in-hospital stays of more than 30 days as end of follow-up. So in our data set, 79% of patients mobilized early, which is similar enough to the 2020 data, which indicated 81% mobilized early. By day 30, roughly half were discharged, 4% had died, 33% lost to follow-up, and 10% end of follow-up. In the table, the discharge rate was 27 per 1,000 patient days among those who mobilized late, and 43 per 1,000 patient days among those who mobilized early. In the graph, on the y-axis, we can see the cumulative incidence function of live discharge. So discharge to home, nursing, or residential care, considering that competing risk of death. The x-axis reflects postoperative inpatient days from day 1 postoperatively to day 30 postoperatively. The dashed line reflects the 21% of patients that mobilized late, and the solid line reflecting those who mobilized early. So we can see that early mobilization was associated with a higher rate of discharge each day for the first 30 days after surgery. And by this 30 days, there was an additional 187 discharges per 1,000 surgeries among those who mobilized early when compared to those who mobilized late. Now, the graph accounts for the competing risk of death, but it doesn't consider those other potential confounders. So we conducted a proportional odds regression model where the cumulative incidence was the outcome variable. And we adjusted the analysis for age, sex, ethnicity, deprivation, comorbidities, fracture type, ASA grade, pre-fracture residence and mobility, time to surgery, procedure type, hospital volume, day of admission, and calendar year of admission. So really the potential confounders that we had access to in the data set. That's not to say that there is the risk of residual confounding in the analyses. So we estimated that early mobilization was associated with a twofold higher adjusted odds of live discharge by 30 days postoperatively when compared to late mobilization. And the results of that analysis are available in more detail in our paper, with the citation is available on the screen. So the next step was to see whether the association varies across subgroups defined by characteristics of patients. So in 2017, the Chartered Society of Physio commissioned a UK physiotherapy hip fracture sprint audit. And in that audit, physiotherapists provided reasons for failure to mobilise early. These reasons included agitation or refusal, and we've used dementia and delirium as proxies in our data, hypotension, poor pre-fracture ambulation, and then we added pre-fracture residence because we thought that these conditions may be more frequently observed in those who are admitted from residential or nursing care. So the descriptive statistics support the suggested subgroups. So the percentage beside each subgroup reflects differences in the proportion of patients mobilised early by the presence of each condition or status. So for example, 10% fewer patients with dementia mobilised early when compared to those without dementia. So given the NHFD is so large, we had sufficient data to simply stratify the analyses by these subgroups. So in other words, we ran the analysis looking solely at people who were from home and then solely at people who were from nursing or residential care. The y-axis reflects the selected subgroups, so pre-fracture residence, pre-fracture mobility, hypotension, dementia, and delirium. The dashed vertical line indicates the point beyond which there is a difference between those who mobilised early and those who mobilised late. The x-axis reflects the results of the proportional odds regression analysis of the cumulative incidence function to estimate the association between mobilisation timing and discharge. The dots reflects the odds ratios, and the line through the dots, the 95% confidence interval. So we can see from the graph that the increased odds were greater for those without dementia, without delirium, who were able to walk outdoors and who were admitted from home. However, to me, the take-home message is that irrespective of subgroup membership, all of those dots are a good distance away from that vertical dashed line. So everybody benefits from early mobilisation, irrespective of whether they have these conditions or whether they've got poorer mobility or they are admitted from nursing or residential care. We do acknowledge that it's likely that the subgroups don't occur in isolation. So it might be more likely that somebody with a diagnosis of dementia is coming in from residential or nursing care than somebody without diagnosis. So we completed a post hoc analysis to consider the additive role of the subgroups, but only those that seem to influence the association between mobilisation timing and discharge. So we dropped hypertension because the odds were similar for those with and without hypertension. Now, this additive analysis indicated that pre-fracture residence and pre-fracture mobility, when considered together, were the factors which more strongly influenced the association between mobilisation timing and discharge. So this modelling suggested that those admitted from home with better ambulation were more likely to be discharged alive early, following early mobilisation, than those who were admitted from residential care with poor ambulation, which is perhaps not a surprise to us. But again, when we look at where the triangles or the circles are, so the odds ratios, they are far away from that dashed vertical line. So irrespective of subgroup membership, either considered in isolation or considered together, patients are benefiting from this early mobilisation. So we looked at our other outcomes. So we looked at 30-day survival and 30-day recovery as binary outcomes. Recovery was considered as no change or an improvement in the measured ability to walk pre-fracture, so indoors only or indoors and outdoors, to 30 days post-fracture. And we used a propensity-weighted logistic regression model. What this means is that instead of simply including potential confounders in an analysis, we matched up people who mobilised late to people who mobilised early based on their baseline characteristics and completed the analysis on the matched sample. So the reason why you do this, it's an effort to reduce selection bias in observational analyses. it's not perfect because you are still limited by the variables that you've observed. So there still is that potential for residual confounding, but it's an extra step that you can take to try to reduce selection bias. So also just to note, the analysis for recovery was conducted separately for those who had indoor ambulation only pre-fracture and for those that had indoor and outdoor ambulation pre-fracture. We didn't include patients that had no pre-fracture mobility in that analysis. So overall, we had complete data for just under 127,000 patients for 30-day survival. And we saw similar results to the previous analysis. So 79% mobilizing early, and the early mobilization associated with a twofold higher odds of survival at 30 days compared with the late mobilization. We had complete data for a lot less patients for 30-day recovery, so just over 33,000. The data is likely not missing at random, so there are potential biases and threats to external validity of the findings of the 30-day recovery analyses. So from the data, for those who were able to mobilize outdoors pre-fracture, 85% mobilized early, and for those with indoor ambulation only, 74% mobilized early. Early mobilization was associated with a 25% higher odds of the recovery of outdoor mobility and a 53% higher odds of the recovery of indoor ambulation. So we graphically presented this in terms of probabilities because odds can be a little bit abstract sometimes. So the top half of this graph reflects overall 30-day survival, and the bottom half reflecting 30-day recovery by pre-fracture ambulation, so indoors or indoors and outdoors. The blue dots reflect those who mobilized early, and the red those who mobilized late. The x-axis for both graphs reflects the probability of a positive outcome, so survival or recovery. The further to the right the dots are, the better the probability of a positive outcome. So we can see that the blue dots are ahead of the red dots for all of the outcomes, indicating a higher probability of a positive outcome for those that mobilized early. So I have hinted to some limitations, and particularly unobserved confounding. So, there is the potential for residual confounding of variables that we didn't have data for. And we also didn't complete multi-level modeling to account for any differences at the facility level. There was a high proportion of loss to follow-up cases in our analysis of time to discharge. Throughout this presentation, I focused on the results from the complete case analysis. We did complete sensitivity analyses for time to discharge and for survival at 30 days, where we imputed missing data and found very similar findings to the complete case analysis. The complete case analysis was actually more conservative in terms of the effect estimates that were generated. We didn't do this for 30-day recovery because the data is not missing at random, and that violates the assumptions of imputation. So again, the results from that analysis need to be taken with a pinch of salt. And then lastly, our subgrouping variables are very crude. We're looking at dementia, yes, no, by an ICD code. But somebody who has a very new diagnosis of dementia may be better reflected by the no dementia group than a dementia group that includes those with moderate to severe dementia. So there is the potential of misclassification in how patients are actually presenting within those subgroups. Nonetheless, we indicate that early mobilization leads to higher odds of survival and discharge, 30-day survival, and tentatively recovery at 30 days compared to late mobilization. Our analysis did suggest there is some inequities in access to early mobilization. Patients with conditions such as dementia, delirium, and hypertension are less likely to mobilize early. Similarly, for those who are admitted from residential or nursing care or with poor pre-fracture function. And this is despite the fact that we've noted a benefit for all of these patients, irrespective of subgroup membership. We know that early mobilization is currently a key performance indicator, and it's been achieved to around 80% of patients in England and Wales. There are still some places that are struggling to achieve this, and we're hoping that it will be considered for inclusion in the next tariff scheme, whatever that scheme structure is going to look like. But internationally, it's not audited in a lot of countries, and it's not offered to a lot of patients. So we are working with the Fragility Fracture Network to speak to clinicians globally to encourage audit and also to increase the proportion of patients that are supported to mobilize early after their surgery. So the next thing is, how did this secondary analysis inform a feasibility randomized controlled trial? Well, I guess for those that have managed to stay with me, you might have noticed this in the graph of the probability of recovering outdoor mobility. So the weighted probabilities are less than 10% at 30 days, which we knew it was going to be low, but perhaps didn't think it would be quite so low. So we looked a little bit closer at the audit data, and we noted that 91% of patients were able to walk outdoors before their fracture. By 30 days, it's around 9%. And we looked to the physiotherapy hip fracture sprint audit, which has recovery at 120 days. And this proportion increases to around 26%. So 1 in 4 patients recover their ability to go outside for fracture, which we thought was really quite low, and maybe there's an opportunity to offer something to try and increase this proportion. So what are we doing in current care? The national survey through the FEMUR trial identified 2 common models of rehab for those discharged home. So the first, early supported discharge with community rehab at home for 4 to 6 weeks, and the second, discharge home under the care of a GP with referral to community care as needed. Not all patients receive physiotherapy and occupational therapy, particularly for the second model. For one centre, less than 10% of patients received either. The survey did indicate components of physiotherapy rehabilitation, predominantly focusing on strengthening, weight-bearing exercises, encouragement of walking and practicing stairs, and transfer practice. So predominantly indoor activities. Outdoor mobility was listed in other for some respondents. So it's likely not due to a lack of wanting to support outdoor mobility, but a lack of resource to be able to do it. Informal conversations with community-based physiotherapists and occupational therapists have indicated that for most places there just isn't resource. In some settings, outdoor mobility is assessed, and in other settings, outdoor mobility might be assessed and practiced once or twice, but very limited to in the near vicinity of somebody's home. And it's not consistent across the UK. So this is in contrast to a review which we completed of 279 patients from 14 studies that suggested their perspective of recovery often required the ability to go outside. So to garden, to go shopping, meet friends or family, go to events, volunteer. I think one study from Canada, there was participation in sports with some people keen to get back skiing, which obviously isn't going to be applicable everywhere. One person I think particularly captured this when they said, I just miss getting up and getting out. I never stayed in. I'd go out in the morning and come back, and then I'd go out again. So what about the evidence? So there's no reference to outdoor mobility in NICE guidance, in the Chartered Society of Physiotherapy Care Standards, or in the American Physical Therapy Association Clinical Practice Guideline, which was released in 2021. So we conducted a systematic review to see whether, for patients with hip fracture, rehabilitation interventions which incorporated an outdoor mobility component increased physical activity, outdoor mobility, endurance, or falls-related self-efficacy. The evidence was incredibly limited. There was some indication of a benefit for outdoor mobility and falls-related self-efficacy. So we went away and completed another systematic review, looking at older adults more broadly, and we stratified the analyses by whether the intervention was targeting a proactive population, so community-dwelling kind of primary care populations, or reactive populations, so targeting older adults after an illness or injury. So we noted benefits of the interventions that targeted reactive populations, on physical activity, endurance, and outdoor mobility, but not falls-related self-efficacy. And promisingly, the effects that were observed were sustained at final follow-up. So the hip fracture review is published, and the reference is there on the screen. The older adult one is just being submitted, but if anybody's interested, I'm happy to share the text. So we then looked to see what did the interventions actually include related to their outdoor mobility components. So the most frequent components were a walking program in conjunction with the psychological component. Less frequent were components related to knowledge or engaging social networks. And that's somewhat in conflict with the review of patient perspectives of recovery, where there was a strong desire for expectations, what should be coming up for them, and also engaging friends and family to support them. So at this point, we knew we wanted to address a gap in care that was meaningful to patients after hip fracture. So we began to explore theoretical frameworks to underpin a future intervention. And one framework that fit quite well was the 2010 Sandra Weber framework, which looks at mobility in older adults. The framework takes a more holistic definition of mobility, and it considers it as the ability to move oneself. So by walking with assistive devices or taking transport, and within environments that move increasingly further away from somebody's home, so to their garden or driveway, local neighborhood, the service community, so thinking GPs, banks, shops, and then the surrounding area and beyond. The concept of mobility is portrayed through 5 fundamental determinants, so physical, cognitive, psychosocial, environmental, and financial. And the determinants will hold different degrees of importance depending on where a person is going and how. But there is a view that they interact with each other and that they get increasingly more complex the further somebody is from their home. So if we think of somebody who has low falls-related self-efficacy, they might avoid going outside their home even if they've got the physical ability to do so. The model also indicated that gender, culture, and biography are cross-cutting influences. So, for example, disability is not equally distributed between men and women, and personal life history might influence somebody's social relationships or their physical activity habits. Hip fracture itself constitutes a major interruption to this framework for mobility, and it's likely that several of the determinants are going to be at play, as well as these cross-cutting influences, when we're thinking of an intervention to support recovery of outdoor mobility. Thinking of the framework, it also brought us to 2 other theories that come into play. So the first being behavior change theory, which considers the need for capability, so both physical and psychological, the opportunity, so thinking about outdoor mobility, maybe social factors, and to some extent the environment, and motivation, so reflective and automatic. And we need all 3 of those to interact to generate the desired behavior of increasing outdoor mobility. We also thought that normalization process theory as an implementation science theory would be important to see how we can embed this practice into work as usual. And the theory includes 4 components. So coherence relates to understanding and making sense of a practice. So making sense of outdoor mobility, what it is in terms of not just walking, but taking transport using assistive devices. Cognitive participation, so engaging and participating in the practice, so bringing it into assessment, bringing it into management. Collective action, so the joint work needed to enact the practice. How do we get the resource in place so that this can be supported? And also reflexive monitoring, so reflecting and appraising the practice over time to ensure it becomes routinely embedded. So once we had our data from the NHFD, we had our review of patient perspectives and our systematic reviews of previous research and potential intervention components, we held 2 intervention development workshops where all of the foundation work was presented, and then we followed a nominal group technique to develop the intervention. So the workshop included 20 participants in each of the workshops. We had patients and carers, community physios, trialists, implementation scientists, behaviour change scientists, as well as experts in rehab after hip fracture. And because we had to do it remotely, which is a negative, it did mean that we were able to have attendance from an international group of experts, which really strengthened, I think, the final proposed intervention. So the output from the workshops included trial parameters, program theories, and also the logic model for the intervention. So we will be targeting adults over the age of 60 who were living at home before their fracture and have planned discharge to home after their fracture, and that they had outdoor mobility pre-fracture. The intervention timeline will be up to a maximum of 12 weeks and will run in the window of around 30 to 120 days post-fracture. The primary outcome for a definitive trial will be quality of life, which was selected by TROOP, our public and patient involvement group. In the feasibility trial, we likely won't see a signal on quality of life because we won't have enough participants. So we'll be looking for a signal that the intervention might work from the University of Alabama Life Space Assessment, which assesses mobility in different life spaces at increasing distances from a participant's home. We'll also capture falls-related self-efficacy, ADL pain, and feasibility outcomes. These additional outcomes are to make sure that we adhere to the core outcome set for hip fracture trials and that we can see whether or not this is going to be feasible or acceptable going forward. We plan to measure at baseline, intervention midpoint, end, and for a subset of patients at 6-month follow-up. Would have liked to look at longer follow-up, but we're restricted by the remit of RFPB and the timeline and the funding. So the program theories state for older adults who were mobile outdoors prior to hip fracture, health-related quality of life post-fracture is enhanced by regaining outdoor mobility, and that the achievement of physical, psychosocial, and cognitive capability to go outside require tailored, structured, and graded support with mechanisms to monitor and preserve gains. What this looks like, I hope this isn't too small on your screens, in terms of our logic model for the intervention. So on the left, we have Weber's determinants, so physical, environmental, psychosocial, financial, and cognitive. And these feed into the intervention components, which are in the white boxes, and that relate to either or both behavior change or normalization process theories. These then feed into our hypothesized outcomes in the green boxes, the dark green being those that we think we can measure. And to, I suppose, look at the white boxes in a little bit more detail, we're proposing a mobility program, which will be tailored to the individual, so to account for those cross-cutting influences of gender, culture, and personal life history, including pre-fracture abilities. And the program will be graded to encourage participants to travel through life spaces further from their own home with support from friends and family or through social prescribing. We will include an individual goal setting with emphasis on realistic short-term rehab goals with a view to longer-term life goals. And we'll include therapist monitoring and feedback both in person and over the phone. Participants will be given access to a video where other older adults speak of their recovery journey with a specific emphasis on staying active, and for some, how recovery led to that new sense of self. And then lastly, we're proposed to include a component to provide training to physiotherapists in managing anxiety related to outdoor mobility among older adults. So where are we now? We've submitted the proposal to RFPB. We'll find the outcome of stage 1 in February 22. And in the meantime, we're working away on 2 other funded projects. So one is a secondary analysis of the physiotherapy sprint audit, and then the other is developing that data-driven stratified approach to acute rehabilitation after hip fracture. Before wrapping up, I know I'm a bit over in time, I'd just say thanks to the funders, so NIHR, UKRI, and the CSP Charitable Trust, and also to acknowledge the teams for the 2 projects who are listed on the screen there for you.